All right, getting into our last couple things for this chapter, not too long of a chapter, we're going to get into the types of body movements. So some of the terms I've used sort of in the last couple sections, but now we're actually going to really get into all the different vocabulary that describes body movements and define them. So here's a huge list of movements at the synovial joints. So we have flexion and extension, abduction and adduction. Notice the difference, abduction versus adduction, a B versus a D. Circumduction, rotation, supination, pronation, dorsiflexion and plantar flexion, inversion and eversion, protraction and retraction, depression and elevation, excursion, superior and inferior rotation, and opposition and reposition. So let's look at some of these. So flexion is anywhere where you are reducing the angle of the joint. So if you flex at the knee, right, you pick your leg up and you kick your leg back so that you bend at the knee. That would be flexion at the knee because the angle at the knee is less, right? If you have your legs straightened out, it's about 180 degrees, but if you flex at the knee, the angle is significantly reduced. Extension is the opposite. You're extending out, you're increasing that angle. So if you were to put your foot back down, right, you have extended at the knee because you have created that 180 degree angle. That's the most that you're able to create there. So that's the example with the knee. We can do that at pretty much any hinge joint. We can also do that with the neck, so extension versus flexion. Extension going back, flexion rolling forward. Abduction and adduction. I like to think of it this way. Adduction with a D. Adduction, you are adding a body part in towards the midline. Whereas abduction, the way I remember it, is if you were to be abducted by aliens, right, you would be taken away. So abduction, you're moving a limb away from the trunk, away from the torso. Circumduction is where you are drawing circles, right? It's the way I like to describe it. So the picture here is not fantastic, but if you were imagining that you had a pen, right, or a whiteboard marker, and you were to draw a circle on the board, but you were only allowed to rotate at the shoulder, right, that would be circumduction. You're drawing a big circle, so you're creating almost like a cone, right? If we think about the shape you would create doing that action, the point of the cone would be your shoulder, and then the rest of the cone be created by you drawing that circle. Rotation is similar to circumduction, although instead of making a circle, we are just going to draw a point. So if we were comparing or explaining circumduction by drawing the circle on the whiteboard by just moving the shoulder, if we were to just draw a single dot and just rotate around to draw a dot on the whiteboard, rotating at the shoulder, that would be rotation. If we look at pronation versus supination, this is going to be where we look at your hands. So pronation, the radius is over the ulna, so your palms are facing back. Versus supination, your palms are facing forward, right? So those are the differences there. If we look at the feet, this is where dorsiflexion and plantar flexion come in. So dorsiflexion, you're flexing your toes up, right? So they're going up towards your leg, versus plantar flexion, you're pointing your toes down like a ballerina. And then inversion and eversion has to do with if you are rolling onto the side of your foot and which direction your sole of your foot or the bottom of your foot is facing. If the bottom of your foot is facing in, right, towards the midline, then that would be inversion. So you'd be like rolling onto the blade of your foot, the outer edge of your foot. That would be inversion. Eversion would be like you rolling onto the inner side of your foot, so on the big toe side, so that you're having the soles of your feet face out laterally. That would be eversion. With retraction and protraction, we talk about the jaw. So if you are to push your jaw outward, so you're kind of to put the bottom teeth of your jaw in front of your upper teeth, right? Then that would be protraction. versus pulling it back, right, so that your upper teeth are in front of your lower teeth, then that would be retraction. You're retracting your jaw backwards. So if you were trying to make your chin disappear, that would be retraction. And then elevation and depression has to do with the positioning of your mandible, your jaw. So if you're chewing, you would go through a series of elevation and depression. Elevation, you're moving your jaw upward, pulling your teeth together. Depression, you'd be like opening your mouth. And then opposition, this would be like using your thumb to touch your other fingers. So if you're touching your fingertips together, your thumb to your index finger, your ring finger, or your middle finger, then that would be opposition, because you're moving your digits to come into contact with each other from opposite sides. Right, here's a list. I'm not going to spend too much time going over and talking about all of these because that's kind of excessive, but we look at least a few of these. The pivot joint, like we mentioned, was between your C1 and C2, so your axis and your atlas vertebra. This is going to allow for just rotational movement. The hinge joint is just going to allow for flexion and extension, so moving a limb out or in. The condyloid, this is going to allow for flexion and extension, but it can also allow for abduction / adduction as well as circumduction movements. And then the saddle, this is going to allow for the same things, the flexion and extension, abduction, adduction, and circumduction, so like your ability to move your thumb. The plane is going to allow for inversion, eversion of the foot, flexion, extension, and lateral flexion of the vertebral column. So we see this in like the intertarsal joints of the foot. We also see this in the articulations between the vertebra. And then the ball and socket, this one has the longest list because this is going to allow us for flexion and extension, abduction and adduction, circumduction, and medial and lateral rotational movements. So your shoulder and your hip joints, they really have the greatest variation of movements compared to the other joints that you have in your body. So let's get into the last thing for this one, and that is the anatomy of selected synovial joints. We're going to talk about some specific joints and the components that make them up. We've been talking about it several times, so why not get a little deeper in with the atlantoaxial joint. This is going to join the atlas and the axis together. Remember, the atlas is C1 and the axis is C2, forming that rotational joint. So just this is that reminder of how they come together, looking at it from the top down, a superior view. Let's also take a peek at the temporomandibular joint. This is going to, or also known as the TMJ, this is going to be what allows you to like chew. So we have the mandibular fossa, so that's going to be where in the temporal bone we kind of dive in. We have that little valley so that the mandibular condyle can fit in. We have the articular tubercle that's going to help form the edge, or one of the extensions to really form that nice little pocket for the mandibular condyle to fit into. Right, and we see there's two joint cavities. There's the superior and the inferior joint cavities, right, as well as an articular capsule on both sides to keep everything in. Remember those basic things, right? We had the articular capsule, we had the synovial membrane shown here in orange, and then the joint cavities themselves. In this case, we have an additional thing of an articular disc in between them. And that's like another piece of cartilage there. All right, the next one is the shoulder joint. This one has a lot of moving parts. This and the knee are both going to have a lot of parts, and you'll definitely see these in the lab. So these are two that you'll need to pay attention to. So do not ignore the shoulder joint. But let's take a peek. So we have our humerus that is locking into that glenoid cavity. Here we have the scapula, so the shoulder blade, and the clavicle coming over the top. We look at the components of this. We have, again, like this is the glenoid cavity, but we also have the glenoid labrum that is coming right here. Are two different capsules that are two different components that make up the articular capsule, the synovial and the fibrous membranes. We see some of the muscles and their tendons joining. So the supraspinatus muscle, right, going over that spine of the scapula, that's going to be the muscle going over there. We have the coracoacromial ligament. This is joining the coracoid acromion of the scapula. We have the subacromial bursa, more articular capsule, and then this is going to be the tendon for the biceps brachii that's going to be joining up into the shoulder there. All right, the next one we are looking at is the elbow joint. So here we see the humerus, we see the ulna, we see how that they're kind of locking into each other. We see the olecranon bursa, which is going to protect the end of that olecranon process. We see a few more bursa, so there's one right here and another coming around here. We see the tricep muscle anchoring down in the back. Bicep is going to anchor down on one side. This is also the brachialis connection point here. We see the synovial membrane, the synovial cavity. We see the articular cartilage from the trochlea of the humerus. And then we see the coronoid process coming up, right, forming that little notch, the trochlear notch. When it comes to the different ligaments and whatnot, we see the annular ligament, which is joining the ulna up to the lateral epicondyle of the humerus. We see the the radial collateral ligament over here. And then we can't really see, we're going to look down here, so we see the medial view, so we see the other side. We see the ulnar collateral ligament as well. Looking at the hip joint, we see the acetabulum with the acetabular labrum in there. Again, creating some space so that we have the synovial fluid inside there. So that's in yellow is the synovial cavity with the articular capsule on each side. In terms of the ligaments we see there, we see the iliofemoral ligament that's going to connect the ilium to the femur. We see the pubofemoral ligament, which is connecting the pubis to the femur. Right, and so the last one we see is the ischiofemoral ligament, which is connecting the ischium to the femur. The second to last one we're looking at is the knee joint. Now this is a big one, so I mean, I don't expect you to memorize everything about all of these different joints, but if you're going to choose at least a couple to really study, it should be the shoulder and the knee. Don't ignore the knee. You're going to see it in lab, and so you're going to have to know some of the components. But let's go ahead and talk about what those components are. Some of which we talked about a little bit when we talked about like bursa and whatnot previously. But let's go ahead and talk about all these different components. So we have the femur, we have the tibia down here and the patella. We have the suprapatellar bursa, the prepatellar bursa, and the infrapatellar bursa. There's also a fat pad just below the patella as well called the infrapatellar fat pad. Here's our synovial cavity. We have our patellar ligament, which is stretching down from the kneecap down to the tibia. And then the tendon of the quadriceps femoris is what's going to link to the kneecap. We have the lateral meniscus here. And then on the back side here, we see the articular capsule, which is going to come across back here, the posterior cruciate ligament, or the PCL, the lateral meniscus, and the anterior cruciate ligament, aka the ACL. Right? So when you think ACL, you probably think of like an athlete getting injured. So let's take a look down here so we can see the different ligaments. So we have the fibular collateral ligament, which is going to link our femur to the fibula. We have our tibial collateral ligament, which is going to link the tibia to the femur. We have the medial patellar retinaculum, and then the lateral patellar retinaculum. But this is really the one we're looking at here, because this is where we see a lot of the injuries occur. If you pay attention to sports, right, you might have heard of people getting like an ACL tear in varying degrees. So here is the anterior view in the front, and here's the posterior end back here. You notice the posterior cruciate ligament is going to, if we're looking at the superior view, it's going to link to the posterior side of the tibia and then come up and anchor over, right, kind of come forward. Whereas the ACL is going to be anchored on the front of the tibia and then anchor across to the back of the femur. So they kind of almost crisscross in a way. Right? And usually what happens if someone tears this is because they made some sort of lateral movement, so some sort of side-to-side movement that allowed for that tear to occur. We look at the ankle joint, there's a million little bones there, so of course there's a lot of ligaments, right? I'm not as worried about the ankle joint though as like the knee and the shoulder though, so just I would pay more attention to those ones than the ones here. We'll at least talk about a few things though. We have the subtalar joint, so that's the talus and the calcaneus coming together. We have the deltoid ligament that's kind of spreading out, right? It's almost triangle shaped, which is probably why it's named the deltoid ligament. That's going to link up towards the medial malleolus and then link to some of the different tarsal bones. We have the posterior and anterior inferior tibiofibular ligaments. Mouthful for a name, right? So one's in the back, one's in the front. They're both inferior to the tibia and the fibula, and they're linking the two together. And then the anterior talofibular ligament. This is going to be what links the fibula to the talus bone. And then the calcaneofibular ligament is going to link the fibula to the calcaneus bone. So like I said, the joint one is pretty crazy. In terms of the specific joints, the ones that I really worry about the most is going to be the shoulder and the knee. Not to say I won't ask anything from these ones, but I'll probably stick with things that are a little bit more surface level with the other joints and really try to put my focus on the shoulder and the knee for something like an exam.